Thank you, sir. Good morning. I'm Su-Jin Park from Sejong General Hospital. Today, I will present a case of conversion to biventricular repair after stage 2 univentricular surgery in hypoplastic left heart syndrome complex in our institute. This is a brief history of the patient. Currently, she is 4 years old, and she was born in June of the year 2010. Initial diagnosis was hypoplastic left heart syndrome with closing ductus, large ASD, and severe TR. The first operation was performed in July of 2010 when she was 18 days old at another hospital, and second operation in October when she was 4 months old, also at another hospital. And this is initial echo findings. Hypoplast variant with small apex forming LV. MV annulus was 12 millimeters, T-valve 18 millimeters, and severe TR. Aortic valve was 4.7 millimeters, and pulmonary valve was 13 millimeters. Ascending aorta 6 millimeters, aortic arch 3.2 millimeters, and the isthmus 3 millimeters. There was no PDA and large ASD, and LSVC was drained to the coronary sinus. With these echo findings, the colleagues at another hospital decided to perform the stage single ventricular repair. This is the brief medical history before she came to our hospital. At 18 days of age, modified Norwood operation and tricuspid valve repair, RV to PA conduit with 3 millimeter Gore-Tex was performed. Extubation was possible at 11 days after the operation, but there was overflow of the pulmonary artery. Echo performed 3 months after the operation still showed remaining TR of grade 2 at the posteroseptal portion. At 4 months of age, bilateral pulsatile BCPS with conduit banding was performed. This is the echo performed at the age of 3 years and 3 months at our institute. There was small apex forming LV. LV size was 31 times 16 millimeters, and the area was 4 centimeters squared. RV size was 46 times 28 millimeters, 13.5 centimeters squared. Mitral valve annulus was 13 millimeters, Z-score was minus 2.4, and the mitral valve opening was 6.5 millimeters. There was no MS or mitral regurgitation. The T-valve annulus was 22 millimeters. The mitral valve motion was restrictive, and TR was grade 2. So this is the video clip. 4-chamber view shows enlarged RV and RA. And then you can see the markedly enlarged coronary sinus. The tricuspid regurgitation of grade 3 with restrictive septal leaflet and prolapse posterior leaflet. And on the short axis view, the LV is D-shaped. And the measurement of LV outflow tract was 6.2 millimeters, and there was no obstruction of the LVOT. This is the cardiac cath that was performed. And on the aortogram, you can see minimal AR, but the evidence of prominent REMA. The REMA was selected, and embolization of the REMA with 8 millimeter and vascular plug 4 was performed. This is the cath data. The CVP was high, and it was 18 millimeter mercury, and the RV end diastolic pressure was 15 millimeter mercury. TR was severe with very good RV systolic function. CT was performed, and moderate to severe LV hypoplasia. The mitral annulus dimension was 18 millimeters. The LVOT dimension was around 10 millimeters, and the outflow tract was very wide. There was mild stenosis of the RPA due to the compression of the aortic descending aorta. This is the captured CT. You could see the moderate to severe LV hypoplasia, and the mitral valve annulus dimension was 18 millimeters. The LVOT dimension was around 10 millimeters, and you could see the wide aortic outflow tract. And you can see the mild RPA stenosis due to the compression of the descending aorta. So this patient, the problem was borderline LV. The volume index was almost 20 milliliter per BSA, severe TR, and increased CVP. So our options were tricuspid valve repair with mechanical valve and extracardiac fontan with fenestration. Second option was TV repair with mechanical valve, and then later fontan operation. And there was biventricular repair. And with these options, we decided to go ahead with the 1.5 repair. This process, the process involved were TV repair, gathering suture of anteroseptal commissure, and resection of secondary chordae of the septal leaflet, and annuloplasty with GA fixed autopericardial strip. The coronary sinus unroofing was done, and ASD closure using bovine pericardium with 6 millimeter diameter fenestration was done, and DKS division and primary repair of the aortic side, and the direct anastomosis of MPA to PA arteries were done, and LVAD support and NO support was done. This is the hospital day course, POD number 2. The patient's vital was stable under LVAD support. The LVAD flow was 60% of the cardiac output, atrial pacing, 120 beats per minute, and NO was stopped. The CVP was around 16 to 20 millimeter mercury, and the LA pressure was 16 to 20 millimeter mercury. This is the echo performed on POD number 5. Good both ventricular function, moderate TR pressure was around 61 millimeter mercury. And on the short axis view, the LV was still D-shaped. LVOT was intact, and fenestration was around 6 millimeters, and the flow was mainly left to right. Okay, on POD number 11, the vital was stable with LVAD support. LA pressure was 15 to 60 millimeter mercury at 30% support of LVAD. And the CVP in LSVC measured on the LSVC was 20 to 24 millimeter mercury. Systemic BP, and LA pressure showed small change after total clamp of VAD line clamping. Total clamping of the VAD line, and the rhythm was sinus of 120 to 130 beats per minute. On POD number 12, LVAD was removed. And POD number 16, on POD number 15, extubation was done, and this is the chest X-ray on POD number 16. You can see the left lung haziness. The body weight was 15.2 kilograms, and LA pressure was 22 to 25 millimeter mercury. CVP was 28 to 32 millimeter mercury measured on the LSVC. And on physical examination, the patient showed really puffy face. So reintubation was done. And on POD number 20, tracheostomy was done. This is POD number 29, still tracheostomy state, minimal ventilator support. Body weight was 14.4 kilograms. On chest X-ray, showed left lung haziness, and LAP line was removed. There was decreased urine output to 10 to 20 millimeter per hour, and she showed a wound, the erythematous change of her wound due to the tracheostomy site. This is the echo performed on POD number 29. You could see the good ventricular function. And mean mitral inflow was 6 millimeter. Mean mitral inflow was 6 millimeter mercury, and the flow through the ASC fenestration was mainly left to right, and there was no TR. And there was moderate TR. Sorry. And on the TR pressure was around 43 millimeter mercury, and the ventricular septum showed slight shifting to the RV side. The fenestration size was around 7 millimeters. However, here is a flow of the RPA Doppler, and the pressure was around 42 millimeter mercury. The fenestration size was around 7 millimeters, and this was the CT that was performed. You could see the wide RVOT, but the RPA showed focal stenosis at the proximal portion, and the minimal dimension was 4.2 millimeters. The distal RPA and the LPA was good. And the LV volume index was 22 milliliter per BSA, which before the operation was 19.8. You could see the pleural effusion of the both lungs. And we performed a cardiac cath. You could see the good LVOT track. However, you could see the focal stenosis of the RPA. So we inserted a stent at the RPA stenotic portion with 10 to 19 millimeter stent. The pressure difference before the stent insertion was 24 millimeter mercury, and it dropped to 7 millimeter mercury after the stenting. The RV end diastolic pressure and LV end diastolic pressure was 20 millimeter mercury. And this is on POD number 53, still tracheostomy state, ventilator mode, SIMV, and FiO2 was 0.5. She showed general edema, and her body weight increased to 6.9 kilograms, and the CVP was 20 to 24 millimeter mercury. And on the chest X-ray, we could see the right lung collapse and effusion. And on the chest tube, there was 300 milliliter per day of drainage. And she still had puffy face, but her oral intake increased. The RPA stent was in place. You could see the echo performed on POD number 53. RPA stent was in place. Pressure gradient was 25 millimeter mercury, but good flow to the distal portion. Mitral valve annulus was 17 millimeters, and the mean pressure gradient was 6 millimeter mercury. The intact VSD fenestration and mean pressure gradient through the ASD was 2.4 millimeter mercury. TR grade was 1, pressure gradient was 45 millimeter mercury. Aortic flow peak velocity was 1.38 meter per sec. This is the chest CT. The RPA dimension increased, but mild indentation was shown due to the ascending aorta, and the LV still showed hypoplasia, but increased than before the surgery, and good LVOT. Good BCPS state, but there was mediastinal fluid collection and large amount of pleural effusion at both sides, and at lower lung showed collapse. This is POD number 64, still on ventilator mode, and body weight was 15.2 kilograms. We thought sedating the patient and extensive lung care would help the patient. So after sedation, the urine output increased, and the general edema improved, and lung and general condition also improved. This is hospital day POD number 84. The general CVP was not measured, but her body weight decreased to 14.5 kilograms, and general edema and abdominal distension was shown. This is the echo. AS defenestration. AS defenestration 6 millimeters. Good RPA stent flow. Good TR gradient. TR grade 2, and through the mitral inflow, the mean pressure was 9 millimeter mercury. And this is PRD number 88. She was on home ventilator mode. Body weight decreased to 13.7 kilograms. She was transferred to general ward, and her saturation was 95%. So. On POD number 132, she was discharged with warfarin and diuretics and captopril. However, the patient was discharged, but on home ventilator, she still showed continuous general edema and on and off respiratory distress due to effusion and intermittent infections. We discussed and decided the mitral stenosis has to be fixed, so on June 22nd, we performed a mitral valve repair with ATS open pivot heart valve, 19 millimeters on the supraannular position, and recreation of ASD was performed. And this is the last echo that was performed in our institute. The mechanical valve was well functioning with mean gradient of 4.2 millimeter mercury. There was no MR, and LVOT diameter was 8 millimeters, and the mean pressure gradient was 14 millimeter mercury. And native mitral valve opening 9 millimeters. The LV volume grew to 32 milliliter per BSA, and the LV function was good. The LA size decreased, and TR was grade 1 to 2. The pressure gradient was 44 millimeter mercury, and the ASD was 3.2 millimeters with 4 millimeter mercury pressure gradient. And this is the most recent chest X-ray performed in June 30th. She's no longer on ventilator. She's no longer ventilator applied, and edema has improved, and she's doing well, and waiting for tracheostomy seal off. So in conclusion, this was a successful biventricular repair after stage 2 univentricular surgery in hypoplastic left heart syndrome complex in our institute. Managing the borderline ALV is clinically challenging. Individualized approach is needed, taking advantage of all the available data. An interstage overall and thorough diagnostic evaluation is critical before proceeding to the next stage operation, always leaving the possibility of biventricular repair in this complex group of patients. Thank you.